discuss features and challenges specific to the management of invasive fungal diseases. So the speaker will elucidate and inform us regarding that. And then the second topic will be fun, learning, spotting the diagnosis of skin infections, common and uncommon skin infections. 101 Dalmatians spot the diagnosis. And my co-chair, I'm Dave Rato, chair of the symposium. My co-chair, Dr. Lara Torno, will introduce our speakers.
Good morning, everyone. It is my pleasure to introduce our two speakers for this morning's convention symposium. Our first speaker, whom I personally know for many years, is currently an associate professor of the Cebu Institute of Medicine. She is a member of the Asia Fungal Working Group, and also she chairs the Infection Control Committee of the Cebu Doctors University Vicente Soto Memorial Medical Center. And I think one thing she would probably be one of her CVs is she's a mother of 3 plus 1. So our first speaker for this morning, Dr. Mitzi Chua. Our second speaker for this morning's convention symposium is the president and the board of trustees of the Philippine Leprosy Mission. She's a member of the training committee of the Department of Dermatology of St. Luke's Medical Center, Quezon City. She's likewise the research officer of the section of dermatology of the Philippine General Hospital, and of course, she's also in the academician, being the course coordinator of Learning Unit 5 of the UP College of Medicine. Ladies and gentlemen, our second speaker for this morning, Dr. Belen Dofitas. So, Mitzi?
Good morning. Thank you, Ma'am Lara, for the introduction. It's very obvious to our friends. I would also like to take this opportunity to congratulate and thank the organizing committee for this ruby celebration of PSMID annual convention. So, for the next, actually this is a short presentation. Over the next 15 to 20 minutes, allow me to breeze through with you a topic that sometimes I feel may not be that relatable to all of us, but I hope with this simplified version we are able to appreciate its rationale and its relevance. So as mentioned, I am a member of the Asia Fungal Working Group, and here we have the website where it contains a wealth of materials if you are into the management or the diagnosis of invasive fungal diseases. And the real disclosure is that I am a bit apprehensive really discussing this topic because I feel that this is an area that is not really exactly the priority insofar as AMS is concerned, because it seems that the bulk of prescriptions would really be more on our antibiotics. But I do hope that we are able to convince ourselves of the importance so that at the end of this session, we hope to be able to understand better the aims, principles, and advantages of antifungal stewardship and how different it is from antibiotic stewardship, strictly bacterial infections, and be able to determine selected best principles of invasive fungal infection management. So again, just one more time, I know sometimes it's an overload of AMS right and left, especially with the new regulatory requirements, but we do know that at the heart of the matter of any AMS program is the patient. So we would like to go for better health outcomes, and at the same time, we would like to save our armamentarium against these infections that cause mortalities and morbidities. But as I've said, our focus for this morning is antifungal stewardship. And how different is that from ANS, or the umbrella, or the big umbrella of ANS? So here we have a table that will show to you some salient differences of the two. In terms of diagnostic and monitoring, it would be good to note that in ANS, it's relatively easier because, as I've said, the concern is really more on the bacterial infections. However, if you talk about fungal infections, and you see this in the right-hand side of your screen, the turnaround time and availability of the diagnostics, plus the confidence of our laboratory staff in terms of interpretation, might actually be more difficult. So it goes without saying that when we talk about epidemiology or incidence rates of infection, it is really down the list compared to bacterial infections. As such, aside from the laboratory aspect, one of the differences would be the clinical experience with treatment and the general familiarity of the staff with the infection spectrum. Again, if you look at the greater than and less than signs, it is quite obvious that there is a difference in terms of that level of confidence and experience in handling IFIs, or we call them IFDs, or invasive fungal diseases. And that is largely because if you look at patient population, they are more commonly the one with the sicker patients. They are on multiple medications, and we even have to consider drug-to-drug interactions. And when we talk about treatment, whether it is for management of an active disease, or we have a spectrum of prophylaxis, which will be briefly breezed through later, then we know it is also of longer duration. Yesterday we had a session on ANS, and it was more on shorter is better, but one of the exceptions might be for fungal infections. So having said that, the unique challenges in DFS would be we need higher case fatality rates. In fact, it's not uncommon in your institutions that favorites among the M&M presentations would be the mortalities. And again, it's not uncommon that invasive fungal disease as a cause of death is called upon. And then it also goes without saying that there is high drug cost. In fact, if I may be a bit liberal on drug estimates, I think I would not be wrong in saying that it costs 10 to 20,000 on a daily basis if we put the patient on an IV antifungal, be it fluconazole, for example, or any of the ECTHYMA candidates. And then before, antifungal resistance was relatively not so much heard of, but we have a few slides on a very notorious bug we call Candida auris to be able to draw that point. And as I've said, it is the complexity of the different patient populations that we handle. So all of these are somewhat different, as I've said, from bacterial infections. Aside from that, we need to have more aggressive management strategies for malignant and inflammatory conditions. What do we mean by that? The subset of populations are more on the low immune system, so immunocompromised, so these are patients with malignancies, or these are patients with connective tissue diseases like lupus. And as such, we need to treat the underlying illness. So again, it becomes a very difficult challenge or task to surmount, that it's not just the infection, but you need to augment or improve the host factor when we talk about stewardship. However, the advantage is that we also see the newer antifungal agents with new formulations that are less toxic and easier to administer. So for example, voriconazole and fluconazole have very good oral bioavailability. So when we talk about the context of stewardship, then the switching from IV to oral becomes a very easy maneuver or strategy to put in the context of AFS. So having said that, what then is the major aim of an antifungal stewardship program in your hospital? Again, we always center around the patient because that is what we are here for, be it a doctor or a healthcare professional. And we can only improve patient outcome if we choose the right drug. So aside from efficacy, we also have to balance them with side effects or toxicity profile. And very common in invasive fungal infection is that we are already halfway through the treatment. We are already in day 10 of fluconazole, for example. But then there is a breakthrough fever. So what type of fever could this be? Is this another fungal infection? Because what is not covered by fluconazole can be what we call the moles, like aspergillus. And then we also have, as I said, antifungal resistance in our midst. We would want to minimize the development of resistance. We would want to look into drug-to-drug interactions, and if we have clinical pharmacists in the audience, that is where we highlight your role, especially in the context of stewardship. And of course, even in developed countries, they always talk about cost efficiency. So cost savings without compromising the health or outcomes of our patient. So again, if I may summarize what I've been saying for the past few minutes in one box, antifungal stewardship simply means choosing the right antifungal for the right patient at the right time with the right dose and duration in order to resolve the infection without causing toxicity and minimizing the impact of resistance. So I hope this far I have convinced you that antifungal stewardship has a very relevant role in our practice. Now, in any process, it's very important to go through, aside from the rationale and the why, the very details of how to set it up. So we have here the 5 W's and the how, which in the next few slides I would like to go through. So the first essential step is the question of who. Who initiates the AFS in the hospital? It has to be a multidisciplinary team. However, as I've said, one of the very difficult parts is that it needs expertise in the management. So we need content experts, and that is where our infectious disease specialists would come in. If we're talking about pulmonary aspergillosis, then the pulmonary doctors, and then drug-to-drug interactions, that's where we can consult our gastroenterologists as well as nephrologists and even endos. And we also have to ask even the pediatric counterparts. So in other words, it takes an effort of a lot of doctors coming in to sit down and look at the pathways or guidelines for IFDs. And the question is, where should we begin? Of course, we have to know our fam. I'm trying to be a millennial here, so we have to know our family. So our family of fungus bugs that you see in your place of practice. And also you have to know your family of medical staff. What is their, of course, attitude towards it, and what are their baseline practices, and you have to mingle that with a protocol that they will embrace. And that is why we want a multidisciplinary team to be involved as early as possible. So we always talk about guidelines and clinical pathways in line with local epidemiology. Again, this used to be something very textbookish or theoretical, but since, as I have mentioned, the AMS is now a regulatory department for the department for hospital accreditation, then the requirement for Antipyria is already there. And because of that, we now have local epidemiology in your respective hospitals. Perhaps the guidelines and the clinical pathways will be easier to follow them. However, the challenge, as I have said, is know your family. And when we talk about IFBs, broadly we can divide them into 3 categories. So we have the medically important fungi are on your left side. That is actually the microscopic structure of a yeast cell. So we have Candida and Cryptococcus. And then we also have at the center our molds. And the most prominent would be Aspergillus. And then here on your right side would be the dimorphic fungi exemplified by histoplasma, which is perhaps not heard of locally, but I believe we do have cases. The problem is really identification. So how then do we diagnose our invasive fungal disease? This is adapted from the European Working Group. They are trying to simplify the different categories. So one is when we talk about a possible invasive fungal disease, it means that there are appropriate host factors and clinical evidence, but the laboratory does not isolate anything. So I guess that's self-explanatory. When we say probable, this means that the patient has a specific host factor, clinical features, and this time, some form of evidence which may not be direct. When we say not direct, it may not necessarily be culture, it may only be a serology or a combination of all the supportive diagnostics. And finally, we have proven, which means that fungal elements were really demonstrated from a sterile site or from the tissue. That's very easy to say theoretically, but my big question is, do you really have access to the diagnostics? By a show of hands, do you have the lactomannan in your laboratories? No? I see not nods, but no's. Yes? How about beta-D-glucan? No also. No hands. I don't believe you are shy. I just believe you really don't have that too. How about PCR for fungal diagnostics? I'm not talking about TB or herpes, but fungal. None. Yes? So I think that the biggest gap that when we speak about invasive fungal infection is really the availability of all these diagnostics. And because of that, let me breeze through how then do we manage, or what is the present status of how we manage fungal infections. It is usually a treatment decision tree of 3, so it's rhyming, of the host factors. As I have said, I've been repeating about host factors, and this next slide, I will just go back to those other factors. This next slide, if they are not so clear from the back, is actually an example of a summary table of what are these risk factors to look for. If I may enumerate some, we have a critically ill patient who underwent abdominal surgery is definitely more at risk of an IFD than a patient who is non-surgical, or for example, even if surgical but underwent only breast surgery. And then we have the presence of hematologic malignancies and neutropenia. Again, these are very common risk factors that will make you put fungal consideration or differential up in the list. Or we also have the presence of prolonged steroid use. That's another risk factor. So again, nothing wrong with a long table because in practice, it will help us to stratify if this patient is indeed at higher risk for an IFD. So let me go back to that decision tree. Then we go to the clinical features. When we talk about clinical features, there is really no what we call pathognomonic sign or symptom of an IFD. So it's really more of a high index of suspicion plus the proper setting of the patient for risk factors. And again, we can never do away without microbiology laboratory. I know that there are pathologists in the audience, and I think that is the challenge. To be able to help us improve in the management would be to be able to improve in the area of diagnostics. So antifungal use is also a little bit different or a little bit more confusing than bacterial infections in that it has different categories or spectrum. And the first of which is we have prophylactic, meaning prevention. We know, for example, if we have an AML patient, leukemia patient who underwent chemotherapy, and since we are able to predict the period of neutropenia, then the patient can be given prophylactic antifungal, such as fluconazole, during the duration of neutropenia to try to prevent any breakthrough invasive fungal infection. Preemptive, I believe, is not really much used locally because it is defined strictly as patients with having a marker for disease, but they are asymptomatic. The problem is not one of you actually raised your hand if you have beta-B-glucan, the lactomannan, or even PCR in your laboratories. So I think what we do, that's why I highlighted in yellow, is empiric. If we have a patient with infection, with prolonged fever, and with prolonged antibiotic use, then we begin to think maybe this is a fungal infection. So that is why sometimes it's difficult to strictly enforce stewardship if there is a diagnostic problem or there is a gap in the diagnostic. This is the same actually as the previous slide, but it's presented differently, and I think in a much simpler manner. As I've said, if there's no disease but you want to prevent it, that's prophylactic. If you have markers, the problem is, do we have markers? Then we can do preemptive. If the patient now has signs and symptoms, namely prolonged fever, unexplained leukocytosis, plus a background of prolonged antibiotics, that's empiric, but we would like to really go for culture-guided treatment. However, in fungal infection, the other challenge is that it might be too late if you wait for your culture. So that's why for a certain subset of patients, it is acceptable to go ahead and start empiric treatment. So let me give you an example for candidemia, because this is, I believe, the most common fungal infection we see in our practice. So in this journal, the review of all candidemia patients meant that all aspects of the care bundle should be looked into. So one is empiric therapy, meaning to say, if you are suspecting bloodstream infection, please do not delay, go ahead and start empirically. And then that is what we call timely treatment. How about lines review? The line there refers to the central line, because we know that the presence of an intrajugular catheter, for example, an IJ cath or any central line or a peak line, would be more high risk for fungal infection. Another would be, why is echocardiography there? Especially if there is persistent candidemia, this may actually mean that there is a deep-seated focus, and this deep-seated focus may be endocarditis. And then, it is always a dictum for candidemia that you have to repeat the blood cultures. I don't know how much the blood culture costs in your institution. Do you agree that at least in Cebu, it's more or less 2,500 to 3,000 per bottle? Do you have that price? I heard that in the big hospitals in Manila, it's about 5,000. But then, how can we establish the clearance of the candidemia or fungemia if we don't order the repeat blood cultures? So I know that guidelines strictly say that if it's candidemia, if it's US guidelines, you repeat the blood cultures daily. Again, maybe that's not cost effective in our setting. There's a Taiwan guideline, and their guideline is repeat it every 2 to 3 days. So it's actually difficult to go with the daily. But I don't know with the other IDs in the audience, but usually I do it 2 to 3 days. And then, why is that important? Because we have to note the first negative culture, and you count plus 14 days for the duration of the antifungal. And then, again, what choice of antifungal? So, again, we have a lot of scoring systems. What I'm showing to you is one of the most simple, known as the Candida Score by the group of Lyon. However, my main objection to this Candida Score is that it looks into colonization. Now, when you say colonization, we don't actually order a lot of cultures. Like, when we say colonization, you get urine, you get sputum culture, you get a rectal swab just to try to see if you have multifocal isolation of Candida. Again, that's a criterion that we cannot readily apply locally. However, we can always have our modified scoring system. This next slide is actually a video that I would like to share with you of a simplified educational module of how to go about candidemia management, and can be very useful in the context of AFS.
CA was admitted to the ICU with sepsis due to pyelonephritis. After 8 days of appropriate antibiotics, she is still febrile without another identified infection. She is colonized with yeast, in her sputum, a wound swab, and she has thrush. She has multiple IV lines, right internal jugular, right arm peripheral, and a left radial arterial line. She also has a Foley catheter. After sending blood, urine, and sputum for culture, CA was started on empiric fluconazole for possible candidemia, or yeast in her blood. Candida species are the third leading cause of bloodstream infection in many ICUs, with an associated mortality of up to 50%. The major risk factor for candidemia is exposure to broad-spectrum antibiotics, usually in the presence of a central venous catheter. Other risk factors include total parenteral nutrition, immunosuppression, dialysis, diabetes, and uncontrolled intra-abdominal infection, all very common in critically ill patients. Candidemia is suspected in patients with appropriate risk factors, fever, and other non-specific signs and symptoms of infection. Hemodynamic instability may also be present. Scoring tools to identify the patient who would benefit from empiric antifungal therapy have been proposed, but none are sensitive and specific enough to reliably predict the at-risk patient. Empiric antifungal therapy has not demonstrated a consistent benefit in clinical outcomes, including mortality. Therefore, candidemia is diagnosed by positive blood cultures, and candida in the blood should always be treated. Guidelines recommend remove and change any IV lines as soon as possible, and start therapy with an echinocandin candida. If Candida albicans is the predominant species in your institution and fluconazole resistance is uncommon, fluconazole is a reasonable choice for azole-naive patients. If an echinocandin candida is started, switch to fluconazole if appropriate once the Candida species is confirmed. For CA, wait for blood cultures to come back before starting fluconazole. Oral or via feeding tube administration of fluconazole is an option for patients who are stable and tolerating feeds. Repeat blood cultures must be sent, as duration of treatment is usually 14 days from the first negative blood culture. Longer courses are needed if there are multiple sites of infection, such as the eye, and ophthalmology consults should be considered, especially in patients with prolonged candidemia. Key messages: identify candidemia risk factors, always treat candida in the blood, use fluconazole if you can, and treat most patients for 14 days from negative cultures.
So I think that in a 1.5 minute video, in a 1.5 minute video, all the essential elements of candidemia management was there, including the stewardship strategy of IV to oral switch. So having said that, we mentioned about antifungal resistance, and I would like to make special mention of Candida auris, which has been actually isolated worldwide since 2009. Now, for those who are active in the laboratory, the challenge is that it can be indistinguishable from most other Candida species. It is germ tube test negative, but some strains may produce pseudohyphae, and the growth may be augmented by a higher temperature at 42 to 45 degrees. So again, for the medtechs or microbiologists around, my question is it feasible to do this in the lab? If we are really suspecting, for example, the Candida is resistant to fluconazole and it's not labrata or crucii, can we elevate the temperature and try to check if you really have auris in our local setting? According to published data, commercially available biochemical-based tests, and I highlighted Vitek 2 because that is the most common machine that I know of that microbiome labs use, can misidentify auris as a wide range of Candida species. Again, this is stewardship working hand in hand with the microbiology laboratory. So these are the list of the different species of Candida that can be misidentified when it's actually auris. So the most common is Haemulomi, and then we do isolate in the Visayas region, we do have Famata, Lusitaniae, Rhodotorula. So I think these should be investigative points for the microbiology lab to try to dig deeper. Is this really all these species, or are we really having the possibility of Candida auris locally? So that is an example of working hand in hand with the microbiome lab insofar as stewardship is concerned. Insofar as treatment is concerned, there is no established MIC, so that makes it very difficult. But it's known to be highly resistant to fluconazole. Some strains are 50% resistance to voriconazole, and that is why for empiric treatment, if we are suspecting auris, it is the echinocandin that is the first line of treatment. So let's leave Candida. Let's go to aspergillosis. So aspergillosis is the most common mold infection that we see in our practice. And most commonly, we see them isolated from the sputum or the endotracheal aspirate. And here we have a spectrum of the different diseases that it causes. But I think if I may be very practical, the most common setting is actually the COPD patient or a patient with structural lung disease with repeated bacterial infections, pneumonias, or any bacterial RTIs, and then we have an isolate of a mold colony. So again, the drug of choice would be voriconazole, and it is another area of stewardship since voriconazole has an IV and an oral formulation, and it has very good oral bioavailability. But again, the local challenge is, if it's voriconazole, it has a lot of drug-to-drug interactions, and its pharmacokinetics is also very, very varied. So if you look into the journals, the recommendation is really to do TDM, or therapeutic drug monitoring. But then, the big question is, not one hospital in the country that I know of has TDM or drug levels for voriconazole. So again, that's a big gap insofar as stewardship is concerned. This is a table that will show to you the different antifungals for which the drug monitoring is recommended. So here we have voriconazole, that's a high recommendation. Posaconazole is recommended for drug levels if it's used as prophylactic. But we should not be discouraged because for the three antifungals, so we have here, for fluconazole, the echinocandins, and amphotericin, there is no strong recommendation for drug level. So it's just really the voriconazole that is the problem when we use them, since we cannot really get the drug levels. So the other molds, as I've said, it's a challenge of culture isolation. So the challenges ahead in antifungal stewardship would then be funding, and of course time, expertise, and we need to persuade ourselves that this is a very, very important infection in our midst. So where to start again? We have to aim to start small. So don't think about the entire hospital. We can go targeted, like we can start with the hematology onco unit, or just in the ICU, or if you belong to a highly specialized center, you can start stewardship in transplant centers. You need to have a needs assessment to begin with. Do you have local guidelines? Do you have diagnostics with rapid TAT, stands for turnaround time? So are we able to have therapeutic drug monitoring, that's TDM, in the near future? For now, do we at least have surveillance data? How common is candidemia? Is it albicans? Is it non-albicans? And do these patients live or die? How are they managed? How long do they stay in the ICU? What is the cost savings for IV to oral switch? And so, this is my last slide. We've discussed about what is AFS. We already know the what and the why, who will initiate it, the where and the how. The final question is when to start. And my challenge to all of us this morning is to start now. Thank you.
Thank you, Dr. Mitzi. Before the second speaker will come, there is an important announcement from the organizers. The certificate of attendance will be emailed to you, so you don't have to fall in line there later on. So it will be emailed to you. I'm sure you have the email app. And then the evaluation form for the whole convention will be distributed during the luncheon symposium. So this is a quick announcement. Due to the interest of time, we will not entertain questions after this. You can ask your questions and then make up or approach the speakers. So we're ready for the second half.
Hello, good morning. Are we still awake? Are we still awake? Okay. Good morning, I'm Dr. Belen Dofitas, and I'm also from Cebu City, actually. But I took up my medicine here in Manila. Okay. And actually this morning, I'm going to show you a lot of photographs. So actually, you might want to move forward if you want to see the photos clearly. Okay. So this is a lot of looking, and not a lot of, information about each disease. Because actually, the task I was given by Dr. Alejandria was to discuss common skin infections and the uncommon skin infections, but giving tips on how you could recognize these infections more easily. Okay? So, I thank somebody who gave me the title 101 Dalmatians, Spot the Diagnosis, because there are really many points you have to look at when you look at the skin. And I'd like to thank my residents from the section of dermatology, Philippine General Hospital, and Dr. Lonabel Encarnacion of St. Luke's Medical Center for sharing some slides and for helping me prepare this presentation. I have no financial conflicts of interest here. So mainly this morning, I'd like you to be able to recognize common and less common but important skin infections in the Philippines just by looking, just by the clinical appearance. Here in Derma, we're more of lookers. We look first rather than ask first. So that's how we are able to widen or broaden our minds regarding the differential diagnosis of what we're seeing. So I'll be showing you a couple of cases. And actually, although we're a large audience right now, I hope you can still try to be interactive when I ask you questions, raise your hand, etc. Okay? Okay, game. So this is the first case I'm going to show you. Take a good look. Okay? So what do we have here? Several thin-walled vesicles. They easily rupture. Okay? And then they form these crusts. Okay? So they could be brown, red, or yellow. What do you think they are? Anybody hazard a guess? Huh? Chickenpox? Yes, this is vesicular. That's true. Anybody else? There's like a lot of crusting. Sometimes you only see the crusts. No more vesicles. Huh? Well, silik na lang in the interest of time. I have to tell you that you're looking at Impetigo contagiosa. Okay? So this is a very common bacterial infection. But sometimes we don't catch it at the vesicular stage because they easily rupture and they dry up, and then they tend to look like honey-colored crusts. So the children are usually affected by impetigo, and sometimes it's usually around the nose, the mouth, or other parts of the body. Of course, hygiene plays a huge role in why it develops. So you just have to remember honey or yellowish brown crusts like with a stuck-on appearance, and they started as superficial blisters or vesicles, and then they became small erosions, and these are caused by group A beta hemolytic streptococci and Staphylococcus aureus. Now, but sometimes it's not as simple as that. These are actually easy to treat. Sometimes you get cases like this. So they are severely crusted. Due to the several wounds in this patient's body, this is my patient, they became heavily crusted, there's foul smelling. So when it becomes this stage, we refer to it as impetiginized. Okay? So again, we think about what is the etiologic agent, and in this situation where it's been chronic wounds on and off for a long time, immunocompromised patient, it's likely to be MRSA. Okay. So the second case, here we have a young man who has small follicular pustules. Follicular meaning they're on the area where the hair comes out. Okay? And it's in the beard area. So we think, what is this? Is this irritation? Because he complains that it comes up after shaving. No? Or is it an infection already? Okay? What do you think? Infection? Oh, many pustules already. Okay. So if it was just inflamed, you'd think maybe just irritation. But when you start seeing pustules, okay, there's a bacterial infection most likely. And we call this folliculitis because it really starts at the hair follicles. When it gets larger, the invasion of the bacteria underneath, and then it's a furuncle or the pigsa, or the boil. So just to recognize them, they're pustules, they pass on hair-bearing areas. The bigger lesions are dome-shaped, and then you can see yung mata, what we call a pointed central area, which is actually corresponding to the hair follicle itself, the opening. And this is an example of a child who has these dome-shaped papules or nodules. And although sometimes you can't easily see the punctum or the opening easily, it tends to come out, especially after some warm compresses of the area. You know, the term pahinugin, where we try to let the pus underneath soften, and we attempt to mobilize the pus underneath so that it will drain out by itself. Then you will see the opening because it starts to drain. Now, what if you encounter a stubborn boil? It won't clear despite oral antibiotics and incision and drainage. Start to think maybe this is not the usual Staphylococcus aureus. This is probably MRSA. And check for the high-risk factors for MRSA in this patient, if that's the case. Maybe you are not using the correct antibiotic to clear it. So then you have to be cultured by it. Okay? So the third case is a 12-year-old boy who has recurrent wounds on the legs. Okay? So they started as itchy papules that he scratched, then they became shallow ulcers. Then they started to have these adherent black crusts or hemorrhagic crusts. Then they leave behind atrophic oval or round scars. And oftentimes we call this among the children, marami siyang barya sa binti. Okay? So, mayaman siya sa scars. So what is this? What do you think? Okay. Sige, tingnan lang natin. But this is quite common, no? Yes. And I'm sure you've seen this before. You've seen this before, right? Never? Yung mga nakatrabaho sa slum area, no? Maraming mga batang may ganito. It's called ECTHYMA. Okay? So, ECTHYMA is still a bacterial infection. It's just that, and it's still the same etiologic agents, no, as strep and staph. But then you know it is ECTHYMA because there are like punched out ulcers. Okay? And then they are usually in the lower legs because they are exposed to insect bites. So often preceded by bites. No? So it would be mainly legs like fleas. No? Fleas are very common, and mosquito bites. Okay? Especially if the child is also allergic to insect bites, then more severely inflamed and the more it will scratch. But ECTHYMA can also turn really bad, such as this case of a 24-year-old female with SLE. When it starts as a hemorrhagic bulla, or a pustule, and then breaks down into a necrotic shallow ulcer, such as this, it's black. You call it ECTHYMA gangrenosum. Okay? Now, it is likely caused by Pseudomonas, and this patient is very likely immunocompromised or hospitalized at this point. Okay? So that's what you have to watch out for. The treatment is, of course, against Pseudomonas or the etiologic agent. And what if the shallow ulcer becomes even deeper and becomes like this? Okay? So this is our patient referred to as PGH. And from a pustule became a shallow ulcer, became a large ulcer, with violaceous overhanging borders, and this very purulent, fibrinous, adherent exudate at the base of the ulcer. So is this an infection? I mean, the first impulse was, yes, it's an infection. There's a lot of pus, right? And it came from a pustule. So you're thinking, oh my God, this is really a severely infected ulcer, and this patient is so immunocompromised. However, this is not necessarily an infection. Not everything that has pus is an infection, remember. Because that purulent exudate may be due to intense inflammation. And such as in this case, it is actually intense inflammation. This is a highly neutrophilic a skin condition called Pyoderma gangrenosum. Okay? So it's called Pyoderma because it looks like a pyoderma, but it is not. Okay? And it's gangrenosum because indeed it does look necrotic at certain points, and it does like really eat into the flesh. And it's very rapid. It's a rapidly progressive disease. But you do not treat this with antibiotics. You probably will not culture something, probably a contaminant. This is actually treated with high-dose steroids. It's associated with malignancies, okay? Or other inflammatory bowel disease also. So remember, not everything with pus is an infection. So the next case actually is a 6-year-old male. He has very several pruritic vesicles and papules on the fingers, genitalia, and then later on there are pustules that develop. No? And then several pruritic papules on the trunk. So what comes to mind? The very first thing that comes to mind in this scenario, what do you think? You're on the right track, scabies. And it is an infestation, of course, caused by the Sarcoptes mites, very common in children. And there is secondary bacterial infection because you scratch them, and of course staph and strep were able to enter the skin. That's why he has pustules. So we commonly find this in the body folds, so the webs of the fingers, the wrists, the pusod, the armpits, the genitalia, and the buttocks. Okay? So sometimes you think, oh, is this an allergy? It doesn't go away. Are these just insect bites? But of course, the very typical location of the itchy papules and vesicles is a giveaway, and especially if there are other members of the family that are similarly affected. And this can be going on for weeks actually. But you also have to watch out among infants and young children. You'll see these persistent inflammatory papules and nodules around the feet, the soles, and even in the palms. You have to think scabies as well, okay? Because they're very itchy, but they seem to be confined to those areas still. And if there are persistent rubbery nodules on the penis, especially of children, this is actually a characteristic of scabies as well. Even after you treat them with anti-scabies treatment, these nodules may persist. They are inflamed. So some corticosteroid actually helps to reduce these inflamed nodules, which are allergic reactions to the scabies mites. So our next case actually has a very fiery red brawny edematous plaque on the leg. There are sharply demarcated borders, but irregular. It's tender. The patient has fever and chills. So what should you think about? Yeah, I heard somebody whispering it. You're erysipelas. Okay? So, although we don't see that often it's more like cellulitis that we see, no? But when you see a well-demarcated tender plaque, and it's very warm, no? It's well-demarcated, and it's edematous, that's erysipelas. Okay? Versus cellulitis, which is not that well-demarcated. Because erysipelas has invaded the lymphatics and the dermis. No? So that's why it is edematous. Okay? Now, and in this case, what do you think this case is? So now we have a 59-year-old male who punctured his arm with a wire while he was working, and then it became erythematous, painful, tender patch, and then became swollen and warm after a few days. And then after that, it developed some pus, blisters, and crusts. So now what is this? So when we see that scenario, it's really, and the patient is in pain, maybe toxic, we have to think already that this is deep, it's cellulitis. So cellulitis is a bacterial infection. It goes all the way to the subcutaneous tissue. So that is the clue here is it's actually deeper, patient appears more serious. And this may lead to sepsis if it is not treated immediately, especially in immunocompromised patients. How about this case? What do you think? Immediately, what's in your mind? Yeah, it is so common. Yes, we think of Tinea, we think of fungal infections. in the inguinal area, in the thighs. Okay? So, this is quite common in tropical countries especially, and this guy happens, let's say, to be a basketball player. Hopefully not from UP, you know, a lot of athletes get this because of the heat and the moisture. Okay, and then kulog siya. It's very itchy, recurrent papules. Yes, it's Tinea cruris or had. Okay, so how do you know? Because it's scaling erythematous plaque. No, it's a raised lesion. Now with sharp or well-demarcated margins. And you can see it's like roundish, what we call polycyclic. It has like several circles in it. It's recurrent, pruritic, scaly. That's the clue. Of course, the KOH is usually positive if it's not yet treated. And Tinea cruris can spread to the rest of the skin, thus becoming Tinea corporis. Okay? So again, you see this very characteristic polycyclic board or well-defined erythematous, and you see papules or bumps on the edges especially, and it's of course expanding. And you see the characteristic, like there's some clearing beginning in the middle, what we call central clearing. And but there are certain Tinea corporis which you don't realize are tinea in the first glance, especially when it's early. And then so the patient decided to self-medicate. Okay, bumili ng BL cream. Hala, lagay ng BL cream. Okay, it seemed to go away for a while and then it would come back, and the patient just kept on applying it. And that would happen, and I actually had a patient who came back looking like this. Okay? So you can see that you don't actually see the characteristic, ring-like or polycyclic appearance of a Tinea corporis. You even see some pustules on top, no? So when you see this sort of, it doesn't exactly look like the usual Tinea corporis, no? But because of medication that has been applied, especially topical steroids, it changes the appearance of the Tinea corporis into something you can't recognize. And we often get this, like even in hospitalized patients, and it's all over. You don't know what it is. You think maybe it's an allergy to something. But when you do the KOH smear amount, it is fungal. So dermatophytic. It is a Tinea corporis, but it is not recognizable, so we call it Tinea incognito, not hidden. But you also have to differentiate this from cutaneous candidiasis, especially in the inguinal folds, in the inguinal area. Is it Tinea cruris or candidiasis? So how to tell? Usually candidiasis is more beefy red. Okay? It's flatter. Okay? And you will tend to see like some scaling on the borders and overhanging skin and satellite papules or pustules at the borders or periphery. That's the typical candidiasis. And of course, the immunocompromise is there, it's quite common. So you see here a lot of, satellite papules. That's a clue. Then, the next case, actually, this one I think you have seen before. Have you seen this? They're like brownish, salmon-colored papules on the trunk, on the back, Or this one is like here in the anterior chest. And they're like very slightly elevated. They're not exactly macules, they're not flat. And then they have very fine scaling. And they're itchy. What do you think? Right? Tama, up. Okay? You're right, Dr. Up. But it's the brown type. Because up is not always white. It can be brown or pink or white. That's why it's called Pityriasis versicolor. Because Pityriasis means scaly and versi means multiple colors. Okay? So you can tell it's up or an because they are sharply, well-defined, uniformly hypopigmented or tan macules. Okay? So you can actually see the ovals, or the rounds. They're round because they came more or less from the hair follicles. That's where they started. Sometimes they're very fine, sometimes you can see the scaling. And this is caused by the Malassezia species, which normally live in our skin. So you can't really say that this is an infection, but it turns pathologic when the environment of the skin is very favorable to its growth, such as a lot of heat, a lot of moisture, and immunocompromise on the part of the patient. So that's when it takes advantage and starts multiplying, becoming pathology. Okay? But, you know, some people are running, they come to me for any white lesion. Say, Doc, natatakot ako. Bakit? Kasi baka meron akong ketong leprosy. Sometimes they just heard me on the radio talking about it. Kaya na medyo napraning sila. Because leprosy can appear whitish. So they start getting panicky about anything whitish. But, you know, you have to know that there is a difference between an and leprosy. You know? So this is a case of Lepromatous leprosy where it happens to be whitish. Okay? Because leprosy can be a bit whitish, flattish also, multiple, covering the trunk as well. Okay? So what's the difference? This, actually what you see as whitish, they're not exactly flat. Sometimes slightly elevated, sometimes there's a coppery color pa rin, no? And then, of course, it's not itchy, it's not scaly, okay? And then even if you treat it with antifungals, it doesn't go away. Okay, so that's the clue that, hey, this is probably not anti. Okay? So this is Lepromatous leprosy. Then the next case, actually, okay, I think this is really obvious, don't you think? What you see is a lot of pustules, right? And this is my patient in 2008. But a lot of pustules, you know, but the difference was, you know, there's pain. There's pain on the chest. So what do you think immediately? Herpes zoster. That's the giveaway. No? Because if you just say pustules, it's like, oh, then the bad case of folliculitis, you know. But when it's associated with paresthesias and pain, and a dermatomal distribution, unilateral especially usually, then you really think herpes zoster or shingles. But it can look like this, okay? So violaceous, purpuric, you know, there are atypical appearances as well. This is also my patient who came in. But then you see that dermatomal distribution is running down the leg. No? So bihira lang yung say bacterial folliculitis or furuncles that are just following a line. No. That's a dermatomal distribution. Think herpes zoster. Okay? So these are the clues. And if there are vesicles that come out, they initially look like chicken pox. So it's clear vesicles on a reddish base. Kaya lang there are so many and they're grouped, which is not like the chicken pox. Okay? Now let's go to the uncommon and the forgotten skin infections here in the Philippines. So I'm very glad that we have a couple of participants from Mindanao. So I'll be talking about something in Mindanao. Okay? So first is the mysterious flesh-eating disease. Ano kaya to? I had a 17-year-old female with a 4-year history of recurrent warm urticarial patches, erythematous, ulcerative, crusted nodules, and bullae, so many lesions. And on skin biopsy, it was lobular paniculitis with leukocytoplastic vasculitis. Okay, so they thought, you know, it's probably autoimmune. Maybe it's a paniculitis. So these are photos of the patient. She's got several atrophic scars on the face, on the back, and on her arms, severely crusted, you know, erosions, you know, which were from the blistering, and they just became necrotic ulcerations on their own. Okay? And so that was found all over, even all the way to the feet. And you can see this flaccid bullae with you know, cloudy contents, which you think, is this pus? You know, is this an infection? The first impulse of any doctor would be to treat it as an infection. And that's what happened to her for 4 years. They kept on pumping her with antibiotics. You know, it just kept on coming back. Because it wasn't exactly, you know, the right thing to do for this. They were not giving her the right antibiotics. You know? So they were thinking, okay, it's so severely ulcerating, Pyoderma gangrenosum ba? Was it lupus? Was it MRSA, cellulitis? You know, because there are other cases like that. This is Pyoderma gangrenosum, no? Can be similar. And this is a patient they thought was SLE, no? So with, you know, these reddish patches. But look at the ears, they are infiltrated. No? So this wasn't actually a case of SLE, it just mimicked it. It was Lepromatous leprosy. And such was the case with our 17-year-old. No? They're indurated, and in this SLE patient, there were also what they thought were lupus, you know, cutaneous signs of lupus. But they were indurated. No? And And so the clue in this patient actually is look at the nerves. Don't just look at the skin. Okay? So well, my colleague referred this patient to me, and then I took a look at the photos, and I agree. Severe lepra reaction. You know, that's our diagnosis, kaagad. No? Because we've seen a couple of these cases in the past. And you can tell also that there is peripheral neuropathy. Look at her hand. Look at her feet. You can see atrophy of the muscles on the hands. On the feet, you can see clawing of the toes. See? And she could not even move her feet. When I did the nerve exam, okay, so there was diffuse peripheral neuropathy. Very tender peripheral nerves and palpation. Motor strength was none in the peroneal muscles. She couldn't lift her foot. Weak hands and as well. Okay? And the clincher was the slit skin smear. Okay? So that is a psychological exam. You can get the results in an hour, actually, if you have the lab. It's the same state as the AFB for tuberculosis. It's modified 0%. So when in doubt, you can do this slit skin smear, and for Lepromatous cases, 6 sites are advised. And true enough, she had positive, rods. So this is a case of lucial phenomenon. This is a very severe type of leper reaction in a diffuse Lepromatous leprosy case. You know why she was not caught easily? Because she didn't have the usual nodules of leprosy. She was just like thickened all over. That's what we call diffuse Lepromatous. Maganda siya tingnan. Okay? It's hard to catch. But she had definitely MRSA as well. That's why she was so crusted. Okay. Now, remember the 3 cardinal signs of leprosy, and this is what I want you to remember above all. Okay? Look for hypopigmented or reddish patches or raised lesions with definite loss of sensation. Repeat, definite loss of sensation to light touch. Yeah? To light touch. Then you could find peripheral neuropathy, either enlarged nerve, tender nerve, or signs of weakness or sensory impairment. And, of course, seeing the bacteria through biopsy or slit skin smear. One of these 3 is enough to confirm leprosy, if you really have the typical signs. Then leper reaction is just actually an immunologic response to the dead or dying M. leprae. Because it triggers that attack on the bacteria when all the antigens are exposed as they are shattered by the antibiotics. And so the body gets inflamed. Type 1 is just the skin gets inflamed, or the nerve is inflamed as well. Type 2 is an erythema nodosum leprosum, which is basically a vasculitis. But it crops of tender nodules on the arms and the trunk, especially in the face. And they really are a bother because they're very difficult to control. Unfortunately, you have to use steroids. Now, this is an interesting part of our lecture. I want you to tell me which of the 2 pictures is leprosy. Alright? So when I point a picture, raise your hand if you think it's leprosy or not. Okay? Game? 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 Okay. Okay. This one, we've got nodular plaques on the ears. Is this leprosy? Raise your hand. There are a few brave souls raising their hands. Okay. It is lupus vulgaris. Okay. Lupus vulgaris is a form of cutaneous tuberculosis, a cousin of leprosy. And it looks like this, okay? But it's softer than leprosy stick. And you'll have the apple jelly look when you do diastole. Okay? So how about this 2? Which is leprosy? How about this child? Raise your hand. Okay, you see this whitish patch on the cheeks, right? This child, raise your hand. Not so much. This child has Pityriasis alba, which is quite common among children, and etiology unknown. But it's just also dry, scaly, hypopigmented, okay? And it's really hard to tell whether it's indeterminate leprosy or not. So indeterminate leprosy is like, it's a prequel to whether you'll get tuberculosis, a mild type, or a severe type of leprosy. Okay? So you still have to monitor this child, no? Even at this stage, if you biopsy this patch, there will be signs of granulomas forming already. But you won't see that in Pityriasis alba, and Pityriasis alba resolves on its own, but also indeterminate leprosy, by the way. Next, which of the two? Is this leprosy? Raise your hand. So all we see are some ill-defined hyperpigmented patches. How about this one? Raise your hand. Okay, let's see. Post-inflammatory hypopigmentation. Huwag kayo mapraning, kawawa naman yung pasyente. Uy, baka leprosy yan. You know, they get so afraid. But, you know, there was inflammation before it became whitish. Okay, so that's why we call it post-inflammatory hypopigmentation. So, and this patient has tuberculoid leprosy. So it's more well-defined whitish patch. Okay, but it's large, huh? I have patients coming to me afraid that they have leprosy because they have a white patch that is like a confetti size. Hindi ganyan ang leprosy, okay? How about these two? Is this leprosy? Raise your hand. Okay. This one? Mahirap, ano? Mahirap ang tao ng derma, no? Okay. Because this is actually Tinea corporis. Okay? So it's really, you can see the ring-like, remember? No? Ring-like appearance. The difference would be probably, this is quite itchy, and leprosy would not be itchy. Okay? More reddish, satellite papule. This one, oh, this one is nice. Which one is this one? Leprosy? Huh? No. This one, leprosy? Yes. Kasi you saw the picture kanina eh. Sige, bonus na nga. Okay, so what is this other lady having? Leukemia cutis. Okay? Can also have these inflamed nodules, you know, chronic on the skin. Okay, so ask the history, etc. And this lady, of course, has erythematosus leprosy. How about this one? Which one is leprosy? This one? Raise your hand. You see the hypopigmented patches? You see the red scaling plaques? Not. How about this one? That's leprosy? Okay, let's see. Yes. This is my patient. She is in leprosy action, actually. That's why it's so inflamed. And the other one, if it's not leprosy, what is it? Much malign psoriasis vulgaris. Okay? In the past, so many people thought it was leprosy. It's not. So it's not an infection at all. It's an inflammatory disease. Okay? But the difference being, psoriasis is quite itchy sometimes, very thick scales. Something that leprosy doesn't really have. But only siguro pagka when it came from inflammation, then it becomes dry skin. Okay? And this one, this is a giveaway. Leprosy? Okay? Leprosy? Yeah. Okay, because yes, it is neurofibromatosis, the nodules are soft. The nodules of leprosy are firm. Okay? That's leprosy. Histoid leprosy. Very firm, shiny nodules. Ito, last na. Okay? I have 5 minutes na lang. Oh no, sige, skip na lang. Skip. Yan. Okay, so many differentials, but you know the 3 cardinal signs already. Ito, this is important for the taga Mindanao. There's a neglected skin disease that time forgot. Way back in year 2000, I went to Maguindanao, no? Sa Datopian, and I saw this boy with thick yellow crusted pruritic pink papillomatous nodules on the ankles. Okay? And also, he had this soft pink volcano-like papilloma and a lot of atrophic scars. So, being a derma, I said, wow, you know, this looks so different from what I've seen before. No? So, what could it be? Secondarily infected insect bites, boils ba, severe impetigo, ECTHYMA, SVK, all of that. But the locals knew what it was. They taught me that it was yours. So, yours. What's yours? Okay. So, but of course, as a derma, I was aware there's such a thing called yours, but you know, I thought, hey, that's been eradicated already, right? Yeah. So actually, there was, I mean, the Muslims call it bakataw. They have a name for it. They're the only ones who have a name for it. So, in the 1950s, there was an eradication campaign. So everybody thought it was eradicated, but apparently not. Okay? So yours is a tropical infectious disease that affects the skin and the bones. Okay? and it's caused by Treponema pallidum pertemue. Okay? So this means that it cannot be distinguished by serology from Treponema pallidum pallidum. Okay? It can only be differentiated by PCR. So yours, however, is not sexually transmitted, but it can be spread by direct skin-to-skin contact, no? And it can also cause ulcers, and maybe in an environment that has, there's lack of basic needs, lack of personal hygiene. So poor areas. And like here in the world, there are 13 countries before that were endemic. Philippines is the 14th country to be endemic because I found it in the year 2000. And I confirmed it last year in an epidemiologic study that found cases of yours in Liguasan Marsh areas. Who's from Liguasan Marsh area here? Sultan Kudarat, Maguindanao, okay. North Cotabato. Okay. You have it there. But it was not reported. So, these are the areas where I found yours. Okay? Active yours, and latent yours, and past yours. Okay, these were like you only had 6 sites studied. Okay? Now, just to go ahead and explain to you what yours is, because it's virtually forgotten. Nobody knows already how it looks. Yeah, and I had to be taught how it looks by looking at several cases way back in the year 2000. So how do you tell? So, since you can't tell it sometimes clinically from syphilis or serologically, you have to base it on epidemiology. You know that the area is endemic for yours, no? Then with a reactive serology and skin lesions that look like that, that's yours, not syphilis. Okay? And there are 3 stages of yours like syphilis: primary, secondary, tertiary. So I saw this boy way back. That's one lesion, that's the primary yaw. And that's secondary yaws. They look like moist cauliflowers all over. Like syphilis, big bang, that's the secondary. That's, again, secondary yaws. You have thick yellow crust. That could look like a severe case of impetigo, but it's not. This is ulcerated yaws. And that could even look like leprosy, but that's still yaws. This is the index case we found last year. A 10-year-old boy with moist cauliflower papillomas on the armpit in North Cotabato. He also had this thick yellow crust on the knees. Another boy had this moist cauliflower look on the upper lip. But he also had papillus bulbous, shiny papules on the buttocks. On the sole of the feet, he had plantar yaw, which they call pamali. So it's like a wound also. And it can cause erosions, so it's called crab yaws because they can't really walk properly when they have it. It can affect the palms as well. And it can leave a lot of scarring, like this 39-year-old female who has latent yaws. She acquired it in childhood. So most of the kids get it. And then they, outgrow it. It becomes latent if it's not treated. So it can look like ECTHYMA even. If it's not treated, around 10% can get bony deformities like this. Okay? Or gangrenosum. Or Lepromatous ulcer or Stewardship or dactylitis. So you have to try to differentiate it from syphilis. Of course, the high index, high risk behavior, malamang syphilis yun. But in a kid, a 4-year-old, do you expect them to have syphilis in the liquid, in the remote area? Not. Okay, so that's when we suspect yaws, either that or maybe another treponema called Tinea. So basically, it's the clinical features, epidemiology, and serology that will clinch the diagnosis. You've got to use non-treponemal and treponemal antibody tests. So what I've been using is the dual pathway platform. And it's a point-of-care test. You get the results in 5 to 15 minutes, and you only need fingerprint blood. So the algorithm of WHO is, since this is an official neglected tropical disease, first you test for treponema antibodies. If positive, test for non-treponema. That's the second step. If positive pa rin and with active skin lesions, yes, you're an active case of yaws. Okay? No active skin lesions, you're a latent case of yaws. So negative treponemal antibody, don't bother testing any further. That's not a case of yaws, maybe it's something else. Okay? Because the treponemal antibodies will be there for life, even if treated. And this is is just a picture of the point-of-care test kit that I have been using, which is from the USA. Okay. And we could do dark field if you have it, but we don't have PCR for you. And it's very easy to treat. One dose azithromycin is 98% effective, comparable to benzathine penicillin. So the key points of my talk now is familiarize yourself with the clinical morphology or appearance of skin infections and know the differential diagnosis. Take a detailed history, further testing if needed, especially if the appearance is atypical. And remember to refer to your friendly dermatologist for diagnosis and early treatment if you can't really, figure it out. Okay? Thank you very much for your attention.
I would like to call back our chair, Dr. Dave Rato, and of course, I would like to call Dr. Isa Alejandria, the Vice President of PSMIB, to help us award the certificates of appreciation to our speakers for this morning. I'm sure everybody wants more, but we are running out of time, so you can ask your questions directly to our speakers. So, we would like the Philippine Society for Microbiology and Infectious Diseases would like to award the certificate of appreciation to our speakers, Dr. Mitzi Chua, for her invaluable insights and expertise as speaker for the Convention Symposium number 6 on the topic of antifungal stewardship. The same certificate of appreciation is awarded to Dr. Belen Dofitas for her lecture on 101 spots for the 40th annual convention. Congratulations to our speakers. And don't forget that your certificates will be emailed to you, and don't forget also to fill up the evaluation forms for this convention. Yeah, and of course, Dr. would like to remind everybody not to be afraid. Your certificates will be emailed to you. So if you haven't given your email addresses, kindly have it noted down by the secretary. So reminder for everyone, 12 to 1:30 is the lunch symposium by MSD on optimizing strategies in the utilization of cephaloxane tazobactam in an era of increasing MDR. So it's going to be a working lunch.